helping anybody, and they actually have a conflict of interest by charging, and the term I hear mainly is huge fees, treating CCSVI without objective data that there is value in this. And so therefore, don't subject yourself to these procedures. Wait for the scientific data before undergoing the CCSVI procedures. And if you actually do this, find another neurologist to provide you care. Okay, so how do you get scientific data? You work with neurologists. The neurologists need to be involved in this, before and the after treatment. So what do neurologists say? Well, if I get involved, people will think I'm in favor of it, and I'll be labeled as the enemy. Because our job is to protect our patients. So there's this problem that I'm going to talk about how we can possibly solve it. All right, so what about patients? What do they say to neurologists? You guys, you'll probably start nodding your head. Yeah, I've done that. Anyway, CCSVI has already helped so many patients, according to Zamboni, especially the internet, and even other doctors. And so therefore, this does help people, and they're totally safe. You have absolutely zero risk. Neurologists do not know the cause of MS, and I start my MS lectures usually, we don't know what causes MS. So we admit that. And that neurologists are afraid of losing their MS-related income, because if this actually works, why do people need to go to neurologists? And then we're overly influenced by drug companies who will lose billions of dollars. So that makes neurologists part of the conspiracy against the CCSVI doctors and against the patients. It's a pretty negative thing to think about, actually. So then they say the treatment decision is between me and my vascular interventionalist doctor, not the neurologist. The current CCSVI research are good enough to convince me. I want to be liberated from MS. It's my body and my money, and goodbye. Does that sound, you've probably heard this before. All right, so let's talk about CCSVI. First of all, the cause of MS is not understood, and we need to have new hypotheses. We need to have people think out of the box. I'm an immunologist, and in the 1970s, I was a T-cell immunologist. There are B cells and T cells, I won't go into the details. But I was a T-cell immunologist, and T cells were thought to cause multiple sclerosis, and B cells had nothing to do with multiple sclerosis. And if anybody went to a meeting and presented data on B cells, they were ridiculed. B cells can't be involved. It doesn't fit my theory. And then they lost their grants, the B-cell immunologists. And then they ended up doing something else in science besides multiple sclerosis because they couldn't get money to fund the research. Now we know that B cells are an incredibly important part of MS. And I wonder if those B-cell immunologists in 1973 to 75, when they were trying to make a foothold in saying there's a B-cell pathology here, if we had listened to them, think of how many more treatments we'd have right now for MS. Because now we know B cells are vitally important. But we shut them out because we were competing with, not because they were wrong, first of all. But second, and maybe more important, we were competing for grants. There's only so much grants from the NIH. If you give it to the B-cell immunologist, you can't give it to the T-cell immunologist. So we were protecting our turf. And Dr. Duncan is nodding her head. She understands this. The politics of science. Anyway, so there are things, and this is not going to be a lecture on what is MS, but there are genetic issues, environmental issues, immunologic issues, and the data is actually looking pretty good for some of the stuff. So we're starting to get a better understanding about the genetics. I won't talk about parasites unless you want me to, but it's very interesting, the role of parasites and viruses, Epstein-Barr virus, mononucleosis virus, vitamin D. Now, vitamin D cures everything, but actually the data in MS looks pretty good too. But there may well be a vascular component in MS. And we've actually known this for years, because we know that the location of the MS plaques or lesions are usually around veins. And that iron deposits can get around veins, and they're from the red blood cells, so they're from the blood system. And some of these CCSVI research has been positive. So there is some indication we should be doing more work about vascular. And that the mixed data, some of it's positive and some of it's not positive with CCSVI, should stimulate further research. And it is. It is. You're going to hear about research today, and you're going to hear about research in the next 6 months. It's going to be very exciting. And I must say, one of the most exciting parts of research is going on in San Diego, the Hubbard Institute. And I'm not going to talk about the data. Hopefully you're going to talk about the data. But using functional MRIs, which you'll hear about later, and relating that to cognition. Functional MRIs are thought to be an objective measurement. You can't change your MRI with a placebo because you feel good. So now we're getting objective data, and that data is very encouraging. So we're on our way. All right, so let me talk about the diagnosis of MS. Now, Dr. Hakey's going to talk to you about the diagnosis of MS, and he's so much smarter than I am that I'm not going to worry about that. So I'm actually just going to tell you about what the data looks like. First of all, Zamboni's pilot data. 100% MS and 0% non-MS, but with other neurologic diseases, that's OMD, and 0% in normals. Well, that was incredibly exciting to everybody except neurologists. And we know that's impossible. It just isn't that simple. And so therefore, when we first saw this, we were totally opposed to this guy. He's obviously biased. His wife has MS. He's out there going to promote something, and using the word liberation is something that you don't want to do when you talk to neurologists with your preliminary data. It's just not something we like very much. Okay, so the most recent data, and this, I've seen some different figures for this, but in general, MS patients were most likely to have it, but other neurologic disease people who didn't have MS also had it, and some people, normal patients, also had it. And then what he also said is that CCSVI is more likely in late MS than in early MS. Well, if it causes MS, you'd expect it to be there early. I mean, doesn't that make sense? If it causes it, it's going to be there at the beginning. He's saying no, it's much more common in the end of the disease, and that therefore is a consequence of MS, not a cause of MS, and it's not congenital. So this is the most recent data, and it's controversial. His conclusions, I think, are controversial. But he's a neurologist, and neurologists want to take things that support their position. Like when I was a T-cell immunologist, the T-cell immunologist work, I really was really excited about that. Somebody who supported some of my own research. Other studies show 0% of patients have CCSVI, and some say 90%. So you can see how we can be sort of confused about this. Anyway, so there are a lot of people with CCSVI evidently that are asymptomatic from it. I'm not going to talk about diagnostic testing inconsistencies because Dr. Hagee can address these for us. But this is what I hear. Why is there inconsistency? First of all, the type of testing varies. Some people say you do it by an MR venography, some people say you do it by Doppler, some people blah, 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 whatever. The expertise of the personnel varies. If I do something and somebody else does the same thing and they don't get the same results, because they didn't know what they were doing. And it's difficult, there's some difficulty separating normals versus CCI versus clinically non-significant CCI. They may have something that doesn't have a clinical significance. And then there's some, I keep hearing about variability. Again, I don't do this for a living. But we're talking about hydration, their head positions, the breathing patterns, and whether they're lying or sitting or whatever, all this stuff changes. So you can get whatever you want to get. That's how neurologists look at it. So if you want to call CCSVI and MS, then you can actually get it just about everybody if you change enough variables. And again, I wait Dr. Hake's clarification. Okay, so let's go to the Zamboni trial. I mean, that is the trial that set all this going, and I thought you should hear what I did. In December of 2009, I was called to ask to write an article about this for the Multiple Sclerosis Association of America. So I read the article. And I read it like it was a drug trial. I said, how would I look at this for another treatment trial? And then I wrote an article about it, which is actually very positive about the fact that somebody's actually looking at something different, which we desperately need. And he stimulated enough thought that we're going to have a lot more research in the next few years that are going to find the answers to this. Okay, he had very small numbers of patients, 35 of relapsing remitting, 20 are secondary progressive, and 10 are primary progressive. This is pretty small numbers. Now we do studies of 1,000 patients.